Okay, welcome everyone. I'm Bethany Hamilton from the National Center for Medical Legal Partnership. Today is December 7th, 2022, and we welcome you to our national audience webinar funded by HRSA, where we'll be discussing how to use the Medical Legal Partnership approach, or MLP, to address the legal needs among racial and ethnic minorities living with HIV. Thank you all for joining us today. Let's go to the next slide. As mentioned, this webinar is funded by HRSA. A couple of housekeeping remarks. All attendees, as you all know, are joined on mute. However, we welcome and invite you to engage on today's webinar. Send questions to the Q&A. So in the Zoom platform, it might be at the top, the bottom, or the side, but you're going to specifically see the Q&A and use that as opposed to the chat. That's where our moderators will be paying greatest attention to be sure that we pull questions from you in the audience. You are welcome to use the chat as well, and our panelists will be in there, as well as I will be in there, and my colleague Danielle Hodgson here from the National Center will be in the chat as well to share some resources. But please send questions through the Q&A. If you need to activate captions on the Zoom platform, select live transcript and then show subtitle. If you need any assistance, and hopefully you can hear me while I say this, if you need any assistance, please email us at ncmlp@gwu.edu for help. And to answer the ubiquitous question, yes, this webinar will be shared, the recording as well as the slide deck, which contains a slew of resources that will be shared or will highlight towards the end of this webinar. All right, let's go to the next slide. So I can tell you who today's special guest moderators are. To avoid wasting any further time, let me just note that we are joined by two very well-versed subject matter experts, one of whom we call our colleague and teammate here at the National Center for Medical Legal Partnership, Kayla McGovern, our center associate, and Omar Martinez, who's an MLP practitioner. You may have seen Omar join us on past webinars. Perhaps you've also seen his research out there in the field. He's now at UCF. And so you'll first hear from Omar, who will provide proper introductions and let you know why you're joining us here today. Omar, without further ado, I'm going to pass the mic on to you. And thank you so much.
Excellent. Thank you so much, Bethany, for that introduction. Good afternoon. Thank you so much for joining us today for our webinar titled Using MLPs to Address Health-Harming Legal Needs Among Racial and Ethnic Minorities Living with HIV. We have put together a stellar group of leaders in the fields to facilitate this important webinar on advancing the science of MLPs to address the growing social and structural conditions impacting people living with HIV. We highlight some of the key structural drivers of disparities in HIV, present on the current landscape of MLP serving people living with HIV, and discuss best practices for screening and evaluation. Kayla McGovern, Center Associate at the National Center for Medical Legal Partnership, and I will be facilitating today's webinar. First, Kayla will set the ground for the need of MLPs and how they could serve those living with HIV. We'll then proceed with a presentation by Sonia Gray on the history of HRSA working with Ryan White clinics. Sonia Gray is a federal supervisor and manager with decades of team leadership and change management and experience in the field of HIV education, training, prevention, and care. She has served in multiple leadership roles at the HIV/AIDS Bureau for over 25 years and currently serves as the team lead with the Bureau for Primary Health Care. We'll also have representation from Women Walker. Erin Lovier and Amy Nelson will be talking about Women Walker's work around providing legal services for those living with HIV and their overall MLP model to serve those in need. Erin is the Senior Director for Health and Legal Integration and Payment Innovation at Women Walker. Erin focuses on the critical collaborations between healthcare services and legal services to promote patient health and wellness by addressing social and structural legal barriers. Amy serves as the Director of Legal Service at Women Walker. To note is Nelson advocacy and commitment in the areas of transgender health. Nelson organized the Name and Gender Change Legal Clinic in 2012, which continues to serve hundreds of transgender populations. Last but not least, we'll hear from the staff at the Legal Clinic for the Disabled in Philadelphia. Teresa Bradson and Andrew Maude will be sharing some of their MLP initiatives across the city, including a newly established initiative with TPAC, an AIDS service organization in Philadelphia to serve people living with HIV. Teresa is the legal director and Dufy Fellow at the Legal Clinic for the Disabled, and Andrew Maude is a staff attorney at the Legal Clinic for the Disabled and the lead attorney for this newly established initiative. After the presentations, we will proceed with a Q&A session. So please feel free to write down your questions and include them in the chat section of this webinar. And Kayla and I will facilitate this Q&A session with the presenters. So Kayla, take it away.
Thank you so much, Omar. And thank you so much, everyone, for taking their time to be here today. It truly is an honor and a pleasure. I would actually like to start off with having everyone think of an experience with a client or patient where the systemic barriers were so great that you felt as if you could not do your job to the best of your ability and provide them, your client or patient, the justice that they deserved. It's unfortunate that I can walk into this space or be here virtually with you all with the assumption that many of you will be able to relate to this feeling and the emotions that come with it. But I do want to allow everyone just a few brief minutes to just allow yourself to get in touch with those feelings again. All right, so I'm now going to briefly tell you about a client of mine who I came to work with very closely during my time as a rapid resource responder, which functions similarly to a case manager in an HIV department for a non-clinical LGBTQ+ nonprofit community center in Chicago. While I met him in his older life, he moved to the United States from his home country in Latin America when he was a young adult without any support systems to lean back on if things didn't go well. When he was diagnosed with HIV and co-occurring conditions, he was fortunate enough to continue living while many of his loved ones, including his longtime roommate and partner, tragically passed away due to HIV-related causes. He advocated for himself, continuing to search for community through various extracurriculars, despite dealing with the various forms of grief from his family's rejection to the deaths of his loved ones. He continued to do his best to stay on top of maintaining his mental and physical health to the best of his ability, despite its rapid decline and lack of support from providers. He reached out and tried to consult with local housing workers to reassess his current housing assistance, given his increasing Medicaid costs, the increasing costs of living in Chicago, the death of his loved one and his roommate. But still, he was unable to prevent his housing assistance being threatened to be revoked along with his housing. Various letters, including from the IRS, threatening further legal action if past due bills, those that he was unable to pay, were not paid immediately. And then finally, in a final moment of desperation and the true tipping point, when he was in the hospital, in critical condition, and able to get in contact with any of his health providers or case managers to let them know that his housing was about to be taken away, while he was undergoing surgery for this internal bleeding that he was dealing with. He reached out with the only number that he could remember from heart, which was my work phone. Now, there are still so many questions that I personally have when reflecting on his story and my time working with him. But there are some things that I know to be extremely true. The first and the most important of those, it wasn't my client's fault, any of it. Because when it comes down to it, the second thing that I know that is true is that none of this had to happen for him or for me. The most recent estimates from the CDC share that at the end of 2019, and if we can go on to the next slide, please. Thank you so much. The most recent estimates from the CDC share that at the end of 2019, an estimated 1,189,700 people aged 13 and older had HIV in the United States, including an estimated 13% of people whose infections had not been diagnosed. The most recent estimates say that around 40% of people in HIV in the US were Black, despite Black people accounting for only 13% of the US population. Additionally, in the US in 2019, there was an estimated 8,900 new HIV infections among Black and gay bisexual men, 7,900 among Hispanic and Latin gay and bisexual men, as compared to 5,100 among white, gay, and bisexual men. When we change our perspective and instead we begin to look at the preventative measures, the current ending the HIV epidemic in the US 2030 target goal is to have 50% of people in the US who are eligible for PrEP to be prescribed it. In 2019, 8% of Black Americans, 14% of Latin Americans, and 60% of white Americans who are eligible for PrEP were prescribed it. These statistics, like my clients' personal life experiences, are the direct results of systemic racism, as well as anti-LGBTQ and HIV criminalization policies and laws. As we begin to transition into our panelists and begin to think about how MLP can address the legal needs among racial and ethnic minorities living with HIV, I also invite us to all reflect and creatively imagine how, in knowing that these systems are actively perpetuating and inflicting harm on our own communities, can we then leverage our positions actively to begin creating new systems built on justice? Thank you, and I look forward to the rest of our panelists.
Thank you, Kayla. Good afternoon. My name is Sonia Hunt Gray, and I'm getting myself together, Kayla. You asked us to put ourselves there, and part of what I am doing today is to share my lived history, if you will, in the history of HIV work, starting circa 1987. And certainly what you just described was a part of the reality then and unfortunately now. And so one part of what I wanted to talk about, as Omar talked about in terms of the healthcare landscape and talking about social needs, and then the harm that happens, the breaches that happen, and the need for the MLPs everywhere. So part of what I'm doing, and again, thank you, Kayla, for grounding us. That's real history, and part of, again, I'm sharing the history of this work, and so that we can continue to move forward. Next slide, please. Thank you very much. As I ground us around the healthcare and the social needs, the healthcare landscape and the social needs, I wanted to start by us looking at the term Sankofa and the Sankofa bird. If you look at, as depicted by the Sankofa is a Ghanaian word meaning go back and fetch it, return and get it. It's a symbol of importance in learning from the past. And if you see the bird is intentionally turning around so that he or she can look back at the past to go back and fetch what's good, what's needed, and how we can move forward. The bird is able, as you can see, to look at all of it, and then we can determine as we look at what's ahead of us, how to bring back what is needed so that we can go forward. In other words, lessons learned. And if I share with you just the history, I started out working as relates to HIV in the Department of Health in Arkansas as the Minority AIDS Coordinator for the state under Dr. M. Joycelyn Elders, who was the first African-American Surgeon General. And I also served as her special advisor for HIV AIDS and working with the faith community. And so part of what I'm doing is similar to Kayla and painting a picture. And so what I'm painting the picture of is lessons learned. So the first lesson is why we do the work we do. It's about our life's purpose, if you will, our quote unquote bigger why in terms of the work that we do and making sure that folks' lives are better. And so after working with Dr. Elders in the as her HIV/AIDS advisor, I worked also with the Centers for Disease Control with national partnerships, and my partner, if you will, was the Black Church. And working with the Black Church, I was working with the denominations with 1 million as their membership in terms so that we can work towards policy development. Back then, I want us to make sure you know I'm going all the way back from circa 1987 to probably 91, 92 now in terms of looking at who these partners are, who do we need to have so that we can quote unquote move the needle forward. And from working with the Centers for Disease Control, I went to Philadelphia, and I know TPAC when you guys are the Philadelphians will talk in the great work that they do in terms of working as the HIV Commission manager, which was the Part A program with the planning bodies, planning councils, and then now with the Ryan White program for 20 plus years, and now with the Bureau of Primary Health Care. But again, looking at this depiction here, what do we fetch? In the early days, we fetched all we had, and all we had at the time was education. We fetched community engagement. We fetched, if you will, going back and what we need now, absolutely need community education, partners, clinics. We were working with solely prevention, not a lot of care, not a lot of medication. We had AZT. Then we had the cocktails, if people remember the multiple medication, if you will. And so now we're at a place where folks don't have to take 20, 30 pills a day. You see the progress. We were looking at a life expectancy of a few months, a year at the most. Definitely not uttering the words ending the HIV epidemic. So we've come a long way. We are now looking at HIV as a chronic treatable condition. We also looked at the fact that we are our brothers and sisters keepers as relates to global work. I was one of the architects for PEPFAR for the global work that we're doing as relates to HIV. So I just wanted to ground from education to global to in treatment, and all of that in between is what we learned in the past, and that we're bringing it forward as relates to where we ultimately want to get as we bring in the World AIDS Day 2022 theme is putting ourselves, our bigger why, to the test to achieving equity to end HIV. So next slide, please. What is health equity? This is one of my favorite words matter, and if you will, and health equity, I can say with my eyes closed, it's when you're striving for the highest possible health care condition for the individual in terms of what that person needs. And equity is not equality. So for example, if I need 2 blood pressure medications and Omar needs 1, the fact that you're providing blood pressure medication and is equal, I'm not going to be able to get to the highest level of attaining my health care needs if it's not health equity. And so as it relates to the social needs, the social determinants of health, and all of those things that I'll continue to talk about as we frame these social needs, and then we talk about how, and then the other panelists would talk about how they keep these needs in the forefront so that people can, at the end of the day, our patients are able to achieve health equity. Next slide, please. As we continue to frame the issues, I can also, when it came to health disparities, if you will, when Kayla was talking about the statistics, you had to make things plain, had to make things, information useful so that people could take it, understand it, and then internalize and make behavioral change. So when you talk about health disparities, when I was doing education, I would talk to folks, especially in the African American community, to make sure that it was plain when you're doing your education. When you make up, and this is what I used to tell people, if you make up this much of the population, 12% of the population, you would think that you would make up, well, maybe 14% of the cases of HIV. But in fact, with the 12% of the population, we're making up 40 to 60% which means that this is something that is very important that we need to address. Folks understood that. And I can still remember my fingers doing this in the 80s and the 90s because, folks were hesitant to get information. There was not a lot out there, but while you were out making the impact in the community, you had to make sure that you were making the information such that folks can use it and understand that if you have disparities here, something needs to be done about it. And it's defined by, as I shared, social, demographic, environmental, and geographic categories. Places where you live makes a difference. Social determinants of health, conditions in the places where people live, work, play, worship, that affect a wide range of health and the quality of life, risk, and outcomes. So if you're talking about social determinants of health, it's important when you talk about the social needs, we're talking about exercise, nutrition, sleep, restorative sleep, if you will, so that people can live healthy lives. When you're talking about exercise, is there a gym in your area? If not, why not? Movement, can you walk? Are there walkable communities? Do you have something as simple as a sidewalk? Social determinants of health, nutrition. I want an apple. They don't serve apples. It's a food desert. Those kinds of things where you may think, well, one may think, okay, what is she talking about? These are the things in life that are in place, that are, if they are in place, that could increase a person's life expectancy and health outcomes. So I just wanted to make sure that we talked about and framed these important social needs as they will be talked about later on when they're breached. Next slide, please. When we're talking about, again, putting ourselves to the test, achieving health equity to end HIV, look at the Ryan White program. Certainly, they put themselves to the test and have done great work, where we see 38 million people across the globe living with HIV. 1.2 million are in the United States, or are Americans. And in 2021, more than half of the folks that were diagnosed living with HIV in the United States were being treated and cared for, received care through the Ryan White HIV services. How wonderful. Looking at virally suppressed individuals, 89.7% inside of the Ryan White care system were virally suppressed. Again, putting ourselves to the test, achieving equity to end HIV. And then the final slide, if you will, final two slides, next slide, please, is just to talk about the Health Center program from the Bureau of Primary Health Care. We have nearly 1,400 health centers. Just wanted to make sure that folks had the, the facts about, the fast facts about the health centers, and 14,000 service delivery sites. Look at the map, we're all over. And then we serve 30 million people, 30 million patients, and we're patient-centered, comprehensive, the whole person integrated care. So we're talking about partnerships, education, training, all of these things that I talked about at the very beginning in terms of Sankofa. Here we are now, community engagement. All of these things are in place so that, again, moving towards ending the HIV epidemic and making sure that folks have the highest quality of life as relates to health equity. Next slide, please. Ending the HIV epidemic, looking at our health centers and the progress. As I said before, health centers deliver critical primary care and HIV prevention services. So in 2021, we had 958 health centers that were providing PrEP, and that included 302 that were providing PrEP, through our affectionately known, we call it PCHIP, which is our primary care HIV prevention funding, which is specific to EHE, or ending the HIV epidemic. And as it looks at the health centers proper, they serve over 25 million patients, our racially and ethnic minorities, if you will, 65%. They provide HIV tests, and they are able to do something that's very important, which from our Sankofa, bringing it back and keeping it, linking people to care. Newly diagnosed and within 30 days. Because at the beginning, if you will, around the 80s, you were not linked into care that quickly. And so if a person is not linked into care, they're lost to care. And if they're not getting the care that they need, or the prep and the services are educated about what they can do, then again, health equity is not attainable. And then to look at what our PCHIP health centers are doing, they're served over nearly 9 million patients, 79% racial or ethnic minorities, hitting the marks, if you will, as relates to ending the HIV/AIDS epidemic, looking at serving and conducting over 1.7 million HIV tests, and making sure that PrEP is prescribed to the patients. And you see the number was 52,000. And again, linking patients. I thought that note was to me to say, oh, it was time for me to stop talking. Sorry, Omar, you threw me off there a little bit. So anyway, they have linked 86% of the newly diagnosed patients to care within 30 days. Again, linkage to care. So as I wrap it up in terms of the last slide, the next slide, please, I just wanted to thank everyone for all of the work that you do, because it is not simple work, it's not hard work, but it's hard work. Heart, H-E-A-R-T work, and it's our linking us to our bigger why, where we get to putting ourselves to the test, achieving equity to end HIV. And again, at the very beginning, that was not something we could see 30 years ago, that we could end HIV, and we can now with everyone working together. So thank you.
Hi, this is Erin Lubier, and I am focused and appreciate the opportunity to be here and share a little of Whitman Walker's history as the first MLP and our efforts to use legal care to address health harming legal needs of racial and ethnic minorities with HIV and the LGBT community. So if you could pull up slide 23, I'm just going to talk for a second and show you a quick timeline, but the piece I'm focused on is Whitman Walker as a first responder during the AIDS epidemic. Our executive director at the time was a lawyer by training, and in those early years received calls that were both heartbreaking and infuriating about things that needed to be solved. While there was little to no medical treatment, many of these situations needed a lawyer. And while he tried to help, it wasn't his primary role, and the pace, unfortunately, and volume far outpaced him. That led to us adding a lawyer in 1986. And legal care in those early days focused on end of life and planning for death, fighting for someone's family of choice to be able to be with them in a hospital room if their family of origin or the hospital refused, fighting stigma and discrimination, terminations from jobs, or hospital workers afraid to deliver meals into the room of someone with HIV, securing disability benefits, fighting insurance denials for AIDS treatment. The theme was fighting to alleviate suffering and offer care and comfort and compassion in those early days. With the introduction of new medications in 1996, the focus really shifted. When I started in the late 90s, even my early practice, I still was losing clients. I lost, dozens of clients in those first few years as a staff attorney. But as we moved from offering primarily end-of-life care, legal care, to people returning to work and planning for the future, and as Sonia put it, whole person, well-being, living legal care. Over time, our organization made that shift from an AIDS service organization, a Ryan White provider, to a federally qualified health center, some of the history that Sonia discussed a few minutes ago. And so I'm going to offer a couple of takeaways around what we've learned in that history. The first takeaway, and if we can jump to slide 24, is really about embracing the need for a specialty workforce that really is focused on no wrong door and how legal care is a part of meeting people where they are. So you'll see on this slide that the patient is at the center, and all of our work together is us navigating around the patient and engaging the patient, but not asking the patient to navigate us. So the framework for lawyers is to remove structural barriers to care, work to address stigma, discrimination, and systemic reform efforts that help remove barriers, this no wrong door approach and meeting people where they are, because we really see that as critical to patient engagement. The second takeaway, and if we could move to slide 27, is around screening and warm handoffs and making those as efficient and easy as possible. And one way we operationalized this, if we could jump to the next slide, that'd be great. Thank you. One way we operationalized this was in 2007, we created a separate unit of staff called our Public Benefits and Insurance Navigation team, or our navigators, and they focused on eligibility and enrollment for health insurance and programs that reduce cost of care. And that included Ryan White programs like ADAP and AIDS Insurance Assistance Program, and then compliance related things like being a federally qualified health center and offering sliding fee discounts to services. So when they screen for insurance and public benefits, they get a lot of details about things like they get a lot of details about legal barriers that someone may face, immigration, identity documents not matching, the loss of a job. And this is patient-centered rather than just asking them screening questions. The role of that navigator is also as a screener to find those pieces that they've listened or heard and then lift those up so that we can refer those to the other parts of the team. And the ones that are legal barriers go directly to our lawyers. This promotes both efficiency, but also a kind of warm embrace and a warm handoff so that clients are not having to re-answer lots of questions that they've already raised to us. And then my third takeaway is part of the MLP and legal specialist work is elevating trends and structural barriers for systemic reform, not just fixing it case by case in our MLP. While time doesn't permit us really to talk a lot about this, I do want to lift up that there are some great resources that the National Center has put together, and they'll be available later. One of which is an example that is from our work at Whitman Walker around addressing medication access for critically and life-saving medication. I'm going to hand it off to my colleague, Amy Nelson, who's going to share a few specific examples that highlight these three takeaway pieces that I've shared and how meeting clients where they are and no wrong door approach is really exemplified in our MLP. Thanks so much.
Thank you, Erin. If we could, oh, perfect. That is the slide. So Amy Nelson, she, her pronouns. Thanks so much for having us here today. I want to expand on the great information that Erin just shared. And I want to talk about how our efforts to adapt to client needs over the years have focused on health equity and reaching communities of color, immigrants, and queer folks. I also want to share a few lessons that we've learned, and my hope is that this will give you a more concrete idea of how our legal program operates within our health center. So first, I want to talk about the development of a new practice area, which Omar mentioned in my introduction, which started in 2011 when the number of requests for assistance with legal name changes ballooned, and we recognized that we needed to ramp up our capacity for this work. And that meant doing a few things: engaging and training volunteers, creating the infrastructure for a monthly legal clinic, developing extensive written guides and templates. As you know, we operate in 3 jurisdictions here, as well as establishing mentors and the supervision team, and ultimately hiring a legal fellow dedicated to supporting the administration of the clinic. So in June of 2012, we launched and hosted our first clinic. We had 12 volunteer lawyers, a team of administrative volunteers, community members, not lawyers, who were eager to be involved, our staff, dinner, and a half dozen clients. And we continued this on a monthly basis. Quickly realized that the demand was strong, and we met after each clinic to debrief and to adapt, to improve our efficiency, and to set clear expectations for the folks coming in. Our goal was to make sure we could meet them where they were and not turn them away. And we knew that the success of this new service depended on our ability to recalibrate. So we recognized that clients coming in for this service were disproportionately people of color, many of whom were not connected to healthcare in any way. They were particularly low income, and about a quarter of them were immigrants. So we decided to add a few other bells and whistles to help our clients meet their goals. So the first thing we did was to add a financial aid counselor to the clinic model. So that, because in DC and neighboring jurisdictions, the process of updating one's identity documents and changing one's name easily exceeds $300. And this expense frequently leads clients to stall or abandon the process. So working with a community group partner, Translaw, we had funds available to help clients navigate the process. Secondly, we added an immigration lawyer. We recognized that folks born outside the United States really needed to consider the impact of changing their documents in conjunction with their other circumstances. Third, we added a behavioral health support because we were sort of shocked with how many clients were coming in for legal support and didn't know that they were also entering a medical clinic and had questions about how to transition with medical supervision and what sort of ancillary services they could access. And so they were eager to talk to a therapist about what that process looked like. And then lastly, we added a public benefits team member from Erin's team that she mentioned, the navigators. Again, because so many folks we found out were taking hormones and transitioning without any sort of medical guidance or assistance. And we wanted to make sure they felt welcome and that we could connect them to resources, get them enrolled in insurance and benefits so that they would return to Whitman Walker, we hoped, or another healthcare provider to transition safely. As a result, the medical patient population of trans and non-binary patients at Whitman Walker jumped from less than 400 in 2012 to well over 2,000 in just a few years. So the big takeaway there for us was that legal care was a gateway to healthcare, sort of the reverse of what we normally see in the MLP situation. So if we could go back 2 slides. Oh, perfect. Thank you so much. So second, I just want to talk about linkage to care. Now, I realize Sonia just talked about linkage to care and was talking about people getting into medical care after an HIV diagnosis. What I want to talk about is linkage to legal care, ensuring that attorney assistance can be accessed regardless of how a patient enters the care continuum. So the slide you see here is similar to the public benefits slide you saw earlier, which displays most of our practice areas. So in terms of process, we learned from the pandemic that the process of handing off a patient to a lawyer or the ease of connecting to legal services is incredibly important, right? Because people feel a sense of urgency with problem solving, and we want to be available to them all day, every day, regardless of whether we're physically there in the office. So we have a couple different mechanisms in place to be sure that we are available to all departments within Whitman Walker all day, every day. Another piece of this is recognizing that access involves serving different demographic groups with different clients with different needs and meeting them where they are. So we recognize, we serve folks different sites throughout the city. And for example, at our site in Southeast DC, our legal clients there are much less likely to be queer or to be immigrants. Folks are likely to be older, more likely to be Black, more likely to be living with HIV, living with extreme poverty. So instead of identity documents or immigration relief, lawyers there work with clients to maintain access to medications, to secure and maintain Social Security benefits, to make sure access to outside medical specialty providers can be maintained, and generally to navigate public benefit systemic errors. And so in the context of health equity, I just want to highlight the role of the lawyer here as a humble problem solver, right? So we see ourselves as somebody who's there to solve the problems as identified by the client, right? To meet to provide an immediate fix or support to the client and to the patient, to the patient and to the medical care team, and to meet them where they are, so that the client can reach their own self-identified health goals rather than some goal that we may put on them from our own point of view. And then lastly, as Erin mentioned, the legal team focuses on addressing negative trends that our clients are facing to solve large-scale structural issues. So this includes systemic reform efforts to solve underlying issues rather than only case-by-case efforts. So this includes public comments on issues impacting our clients to change a policy or law, working directly with local courts or administrative agencies to make processes and procedures more client-friendly. And we find that that work is pretty successful. So thank you very much.
Hi, everyone. Thank you for being here today. My name is Teresa Brabson, and I'm the legal director at the Legal Clinic for the Disabled. I've been with the clinic for about 10 years now, and I was initially drawn to it because of the MLP model and the work that LCD was doing. So I'm grateful for the opportunity to be here and share our experience with you all. So we thought that we would start by just sharing a bit about LCD, the Legal Clinic for the Disabled, what we do and who we serve. So we provide free civil legal services to low-income people who have chronic physical or mental health conditions in Philadelphia and the surrounding counties. We are, most of our attorneys are generalists. We use a modified iHelp screener, and so we screen for a variety of unmet legal needs. We did recently create a housing initiative because of the eviction and habitability crisis that we're seeing here in Philadelphia, and I'm sure that many of you are seeing across the country. And ultimately, our goal is to help clients overcome legal obstacles that might otherwise affect their independence, their health, their safety, and their quality of life. And that's where this medical legal partnership model is so important, because it's bringing together these disciplines. We're not just working as lawyers. We're working as lawyers alongside the healthcare partners, alongside the social workers, and a variety of team members to ultimately, improve that quality of life. Next slide, please. So I assume that everyone on here is at least somewhat familiar with the medical legal partnership model, but the way that we do it at LCD is we are on site at each of our sites. COVID, of course, threw a bit of a wrench in that, but we're happy to say that we're back on site at each of our sites. And we ultimately, each site is different in the sense that we adapt to workflow, we adapt our screening, our referral process, even where we sit, depending on the site and what the clinic flow is. We're all working though towards the goal of universal screening. So it's our goal to try to connect with any patient who comes into the health center or hospital who may want some legal services, and to maintain that on-site presence so that we can have the warm handoff from the healthcare or the social work team to the legal team. So we are actually now, we have 7 partnerships across 9 sites in Philadelphia. So with Project Home, Stephen Klein Wellness Center, and the Hub of Hope, that serves homeless and at-risk homeless individuals. St. Christopher's Hospital for Children, the Family Practice and Counseling Network, it's a nurse-managed FQHC that has 3 sites. Nemours Children's Health, which is at Thomas Jefferson University here in Philadelphia. And the focus of today's presentation, the Philadelphia AIDS Consortium. Next slide.
All right, I'll take over. So good afternoon, everyone. My name is Andrew Maude, and I'm a staff attorney here at the Legal Clinic for the Disabled. And I am the attorney working at TPAC in partnership with the NIH-funded study. TPAC and LCD are working together implementing an MLP on site to assist individuals living with HIV and exploring the benefits of legal support as a part of their care continuum. This study is really, I would say, probably the next phase where it's being implemented, the training program established under the Organizational Partnership for Healthy Living which has designed educational models to train healthcare providers or social supports providers who are identifying the individuals in the study to integrate, legal support into their care. These educational models are, conversations or education around relevant areas of law and how to screen patients for these needs. And in particular, we use a really resiliency-based screener and questionnaire, which Teresa is going to touch upon to identify these areas of support that our clients are looking for.
And I just want to touch on, training for us comes in a variety of different ways. So it's the formal training that may be clinic-wide or educational series for the patients and community members. It can be one-on-one trainings during onboarding so that we're introducing new team members to what is a medical legal partnership, because they may have never heard of that before. And also being available for curbside consults. So someone comes in and says, hey, this patient said this, I'm not really sure if this is a legal issue or, what does that mean? Kind of helping to expand the knowledge of every team member. We benefit from their expertise and they benefit from ours. So just focusing on that ongoing training, especially with a partnership like TPAC, where we're just starting. And we really, it helps with the buy-in and just kind of keeping that momentum going. Next slide, please. So thinking about what it looks like on the ground, Andrew mentioned the resiliency-based screener. And so what that is we used to work with a screener that was problem-oriented, and it had based on the iHelp categories, do you have a problem with your landlord? Are you having issues getting repairs? Kind of going through with a more, let's just identify the issue. But what we found and what our goal is to really recognize the autonomy and the resilience of the communities that we're serving. And so people may have an issue that is on their plate, but they might not want to deal with it that day. And that's perfectly reasonable for them. And that's their choice. So recognizing, rather than phrasing from, do you have a problem with, moving towards, would you like help with? So it's in their court, the ball is in their court to identify, yes, I'm having this issue. Yes, I would like help today. And making sure that when that screener is introduced, there's an acknowledgement of, I'm not just asking you this to ask you, I'm asking you this because there's someone here who's a member of our team who can actually provide services and assist. We also redid our, so the questionnaire is, like I mentioned, resiliency-based, but we also simplified it. So rather than having full questions, we now have icons and short phrases for a couple different reasons. It increased the literacy access, but it also, sometimes when people come into these clinics, they're given a bunch of different papers and it could get lost in the shuffle. So we really wanted to try to reduce the screener fatigue, reduce, and really increase engagement, I should say.
And to talk about the study, on the ground. So in essence, that screener is incorporated into the study, and the two social support coordinators that have been identified at TPAC use this study as a part of their assessment to see if the individual will actually qualify for the study. And then, highlight whether or not they have screened for a health harming legal need, And then at that point in time, the referral will be made to me. If the patient doesn't screen positive for a legal need, but screens positive for a social need or an issue that I can address legally, then other resources, supports are provided to the patient at that time. As a part of the continuum of care, I'm on site 1 day a week for in-person consultations. So essentially, once the patient is screened for the study, and if they are screened positive for a legal need, they are scheduled for an appointment with me in person. And during that 30-minute session, I'm able to consult with them and provide legal advice. I think I've only been on site at TPAC for a short period of time, but the idea to have an attorney physically present, particularly now coming out of the pandemic, has been helpful for relationship building purposes. One, with TPAC staff, right, the buy-in and through the MLP model of what we do and what we can offer patients and the care providers to help patient outcomes. And also relationship building with the clients. The majority of our clients have experienced past trauma, either with the legal system or outside of it, and are, low income. So it's important that I'm present and have a space on site that I can meet with them and build that attorney-client relationship. And like I said, you become part of the patient's care team. And I think if you are on site, the staff members certainly at the clinic see you as a part of the team, overall team. The in-person sessions last about 30 minutes to an hour. I can provide legal advice. And then, I support the patient after that initial consultation if needed, depending on the type of legal issue. So for example, if they're court involved, if they are facing eviction and they need legal representation in landlord-tenant court, that is a service that I can provide them and a support that I can carry them through until the legal outcome is complete. As a part of the study, the study team, they perform their final assessments after that initial touch point with me, and they're tracking health impact and then also a patient's viral load count at the end of the study. Next slide, please. So what we've seen so far, we've only been on site at TPAC for a short period of time, since about mid-October, seeing patients, but we've served 14 clients so far. The TPAC community is, diverse, and so not only people living with HIV, but low-income immigrant community that this organization is providing services to. So we've had the opportunity to provide our service to those clients, as well as to study-eligible patients as well. And the legal issues addressed really reflect, I think, the population. We've helped with 6 patients who have had advanced planning questions, 3 landlord-tenant issues, domestic violence, and another issue that we've seen prevalent just over the last few weeks there, and then a few miscellaneous legal issues that we've been able to consult on with patients. But I see that it's working, anecdotally on site. I can, there's been community support. Just as an example, we've had a volunteer at TPAC who's reached out to me looking for a flyer. She works with, transgender individuals and has a support group that she runs on her own, and was looking to be able to offer services for participation in the study. And for provider education, speaking to some specific examples that Teresa was mentioning earlier, I had a therapist at TPAC ask me in consult about, domestic violence and divorce questions, and not sure if I could address a legal issue, but it's that having that one-on-one, consultation on site together to see if this person would, 1, be able to participate in the study, and then 2, could I help them address the legal issues that they were having. And we're also providing broader educational support in the form of, a luncheon. I'm going to be on site tomorrow, consulting about landlord-tenant issues, and we have, future plans to address other relevant areas of law as a part of that prong of the study.
Yeah, and as this partnership grows, we're excited to think about other ways that we can engage with the community, the community, both the patient community, the provider community, but also the larger legal community. So thinking about what are some areas that are ripe for having a clinic, or having either a community education event, or engaging with pro bono providers to come in and do a one-stop shop legal clinic, say around planning documents, so that we can serve a larger number of individuals. We can, get the buy-in from the private bar, and ultimately, kind of get more bang for our buck and send more people home after that clinic with the executed documents. So trying to think creatively of, yes, we're on the ground, we're doing those one-on-one consults, but how can we serve the maximum amount of people the most efficiently? And with that, we thank you, and we'll hand it back to Omar.
Excellent. First, thank you so much for those excellent presentations. A few thoughts and reflections that I have. You know, we do know that Black and Brown communities continue to be disproportionately impacted by HIV. Based on the latest CDC data, we saw a significant increase of new HIV diagnoses among gay and bisexual Latino men, among Black sexual minority men, and Black women. We also know, and Sonia did a good job highlighting some of these upstream factors and the social and structural determinants of disparities in HIV, right? Including structural racism, discrimination and its manifestation, housing and food insecurity, unemployment, immigration status, healthcare access, and incarcerations. We also had great presentations about innovative MLP models currently out there serving people living with HIV. What started as a gay men's clinic turned into the first MLP in the country, right? And currently, Women Walkers integrated patient-centered care model includes 3 components, right? Navigation services where peers are leading the model and the cohesiveness of MLPs. Patient-centered screening conducted by that peer and that navigator, right? And provision of that warm handoff approach to the attorney on site, and critically important, elevating the voices of those impacted by HIV by intentionally focusing on advocacy and on advocacy work. We also learn about the impact of women walker pro bono clinics and the cost-benefit approach of using that pro bono clinic to serve trans population. LCD model, legal clinic for the disabled, currently has 7 sites in the city of Philadelphia, acknowledging and adapting to those clinics based on patient demographics, right? From Children's Hospital to those serving people living with HIV. Also adapting to new challenges, right? Philadelphia has a major housing crisis going on now across, similar to other major urban settings, and being responsive to that through in-service and community engagement initiative, talking about landlord-tenant issues impacting Black and Brown communities. I was also fascinated to learn more about the use and integration of resiliency-based questionnaire across all sites, right? The focus and emphasis on peer-led approaches, right? Once again, these peers are leading the working of this medical legal partnerships. Also, the relevance, Andrew highlighted, as well as Erin and Amy, the relevance and impact of having the attorney on site, right? In particular, to build that relationship with the client and the staff at those sites, acknowledging the history of mistreatment, the lack of trust by folks impacted by HIV with attorneys, right, and the legal system, and also the exciting initiative that are coming on, including expanding pro bono clinics, leveraging the connections with the local board to provide other type of legal services for those in Philadelphia. With that, I will pass it up to Kayla to see if they have any other thoughts, points.
Awesome. Well, thank you so much, Omar, for that wonderful overview. I am not quite sure that I could have done as great of a job as you, hitting all of those key points. And thank you once again to all of our panelists for taking the time out of your day to lead us in these really, really important presentations. I think if there's one thing that I can add that I really appreciated that I believe each of our panelists pointed out in their presentations was the importance of centering back the power on our clients and our patients, because they understand their own perspectives and their own experiences better than anyone else. And so how can we, whether we are medical providers, legal aid providers, somewhere else in the middle, how can we begin to shift the way that we do our work, and then begin to, as so many of our panelists say, look towards the future and shift our policies and our systems as we are continuing to do this on the ground action. So with that, I am going to go ahead and turn it over to Omar to see if he has any questions for our panelists before opening up for the Q&A session.
Yeah, no, I'm going to start taking questions from the Q&A. We have our first question. What is the payment funding model for these MLPs? And are the visits covered under Medicaid or other insurance? And I will pass it on first to Erin on that question.
Sure, thank you. So these services are recognized as enabling services as part of the package of things you can deliver as an FQHC. So that is one opportunity to bake them into the costs if you put them in scope as part of your FQHC. Our services, in addition, they're not billable to insurance, but they are services that those partnerships with the local bar and other attorneys, we do specific fundraising directly for legal services. And we have a number of grants, Ryan White grant funds for legal services, as well as from the local bar associations for the different jurisdictions, and then the allocated resources from the city directly for access to legal services. So for DC and Maryland and Virginia, those are some of the sources of funding that we all use.
We'll also love to hear from Teresa and Andrew. You have 7 sites and different sites and different models. So if you can talk a little bit more about the payment and funding model for these MLPs, that would be great.
Sure. Yeah, so we have a variety of different funding streams. With TPAC, it's an NIH funded study, so it is fully covered, thankfully, in that sense. We also have, we do get some. Finally, it took us at some sites 10 years to get funding directly from our partner sites. So it varies from a smaller fraction to most of at least the salary of the staff on site. We also recently secured a partnership with AmeriHealth, also known as Keystone First here in Philadelphia. And they're funding our partnership with Nemours Children's, as well as a community-based, the care coordinators in the community are screening the high utilizers for unmet legal needs, and we're partnering with them to address those as well. And like Erin said, we get a lot of foundation and grant support. I feel like I'm constantly either writing a grant proposal or a grant report, but it's to serve our patients and our clients, so.
Excellent. Andrew or Amy or Sonia, anything else to add on that?
Not on my end, Omar. Thank you.
Excellent. We do have sorry, Amy? Nothing else? Okay, good. We have another question from the audience. How can health centers engage with local attorneys to implement an MLP? And one of my questions was also related to that and the processes of establishing these pro bono clinics with pro bono attorneys with local bars. So can you talk a little bit more about that type of engagement with local attorneys and local bar associations? Erin?
So I just want to distinguish with that first question, just the difference in that Whitman Walker, our attorneys are part of our staff, right? We hire directly. And so our medical legal partnership is, we are part of the care team embedded in the health center, but we're all employed by the same organization. And then I think my colleagues have the standalone legal services that are going in and are embedded on site, but they're 2 separate organizations. So the question seems to both imply, like, how would you start it as a health center? And I just wanted to lift those distinctions up, because you could hire within, right, as part of the health center, or engage directly with attorneys, from local legal services. And we have lots of those models, across the country. And I think I think some of the takeaway messages from all of us were really looking at what the specific patient need is and what are you trying to solve, and then looking for synergy with your outside partner on entities that provide legal services that address that particular need. So you're really matching up that. So like if housing is the number one priority you want to look at, partnering with a legal services provider that provides landlord, tenant, and other representation on those issues is likely a really nice, kind of mix. And the other is looking for a partner that really aligns with the way that you see delivering these services, because I think those are some of the things that make it more successful is around, critical alignment, providing those services, and investment in the service of that patient population on that particular issue.
And yeah, Erin, I think you did a great job of summarizing it, but I'll just expand a bit. In our experience, so we have the 7 partnerships, and each of them have started a little bit differently. Some we've approached the partner and said, hey, you're in a community where we want to be. We actually started at McGee Rehab Hospital. We are not, we're a separate nonprofit, but they provide office space and other in-kind support to us. So, we were kind of born from that model, and then it just grew. Others have come to us and said, hey, we know that this is what you do. This is what we're interested in doing. Can we make this happen? I also, again, want to reiterate what Erin said about, finding a legal services agency that aligns with what you're looking for. Every agency does it differently and has their own kind of spin on medical legal partnerships. So is it feasible for your clinic to have someone on site? Or are you looking for something that's more of a screen and refer, and you're making that connection, but it's not necessarily as integrated as some of the other sites? So thinking about resources, doing a needs assessment so that you have a clear idea of, we may think we know what the community wants to prioritize, but that's not our call. It's the community identifying what are the needs that we want to address, and then how can we make sure that we're partnering either with the right legal aid agency, or if you're a legal aid agency like us, where we know housing issues are pervasive across the city. And so pretty much any low-income community and health center or hospital that we go to, we're going to see people who have unmet housing needs. And so just identifying by location, ideology, resources, all of that.
Excellent. Anyone else want to add to that point? Okay, I do have a question, and we got another one from the audience, but I'm going to proceed with mine, and then we're going to go to that for the audience. I know that advocacy work is a core component of both LCD and Women and Walker. From amicus brief to writing reports, to addressing HIV criminalization laws across the country. So I was wondering if you can talk a little bit more about that advocacy work of LCD and Women and Walker. That would be great.
Sure. So our advocacy, we do both kind of internal advocacy. How can we look at the practice, and how can we improve to make sure that there's equity with how providers respond to requests for medical certifications or caregiver forms for TANF, things like that. So how can we advocate for equity within the organization or within the partnership, but then how can we take it and, what we're learning on the ground, how can we take that to amplify the voices of our community and make sure that there's positive policy and positive progress? So one example, when Philadelphia, at this point, I think it was about 5 years ago, but COVID could have added plus or minus 3 years to that. When Philadelphia was first looking at the housing crisis and what we were going to do about it as a city council hosted a hearing session. And so our MLP team actually came together and testified as a group and looked at how does housing impact from a health perspective. So we had our medical champion. How does housing impact? What's the impact of this from the legal perspective? We had our executive director testify. And most importantly, we had one of the patient's clients who came from one of our medical legal partnerships who was dealing with horrible housing conditions. She testified about the impact of having this advocacy, both from the medical and the legal perspective, and how that really improved the situation for her family. And so ultimately, thankfully, the Philadelphia Eviction Prevention Project was born, and Philly's paying attention to it. But it was taking what we saw, it was both taking what we saw on the ground, but then also engaging with the different stakeholders so that every perspective was heard.
I'll jump in just to highlight a couple of things. Very similar to Teresa, there's a lot of both internal and external relationships that we're looking at and trying to improve the systems overall. When we see specific things that we've had to solve more than a couple of times as either an intervention by our navigators or by our legal team or by a medical provider, behavioral health provider, we are immediately looking as, kind of a legal team around, is there something that we could do to actually change these things coming in? Like, can we get this actually fixed systemically? So, we had an issue recently with prior authorization on MAT services for substance use treatment. And we had one Medicaid MCO that was requiring both not just a prior authorization, but additional clinical documentation like urinalysis in a very specific amount of time. And, those are life-threatening if someone is off of Suboxone or other treatment protocols because they can't get it because of a prior authorization process, which is really at odds with the city's priority around ending the opioid epidemic. So we went directly to the Medicaid director after trying to engage with the MCO ourselves by writing a letter and clinically explaining why this was inappropriate, and ultimately just bypassed that when we were unsuccessful and got it solved by guidance directly from the Medicaid director and the chief medical officer at Medicaid saying, you can't do that, MCO. You need to actually eliminate that part of your prior authorization criteria to be in line with guidance. So that is one, one example of that. And then the second thing I would say is that all of the members of our team who have any kind of expertise on a different issue, we are sitting in community with different stakeholder groups to make sure that we are both listening and hearing what other organizations or other people impacted are experiencing, and then we're lifting up the experiences that we have had representing clients with barriers to whatever that service or issue is, to make sure that we are in coalition trying to work to improve whatever the systemic thing is. And I think Amy wanted to highlight a couple of additional opportunities there too.
All right, thanks, Erin. So in a parallel fashion, we are focused on a lot of local and national issues impacting trans and non-binary folks. And so one area where we've been very involved here in our tri-jurisdiction area has been around DMV changes and the availability of X-gender markers on state-issued identity documents and what it takes to change one's gender marker. So I'm pleased to share that at this point, all three jurisdictions allow for self-attestation with respect to gender marker, and that all three offer the X-gender marker as a third option. When we started this clinic, Virginia wanted some sort of medical documentation in order to change the gender marker on a driver's license, and the same was true for Maryland. And so we've seen all three states, all three jurisdictions change quite a bit. And then most recently, we've been part of a judicial working group in Maryland that is on the verge of releasing new forms for both the name and gender change process in Maryland that will finally eliminate the publication requirement, which is both a privacy concern and an unneeded expense for our clients. And so we're thrilled to see that finally coming to pass. We were a part of the effort to eliminate the publication requirement in DC many years ago. And so, there are opportunities like that where it's a very concrete hurdle that exists, in the process, and we can work to change that. I want to just also mention another area where we are, promoting gender affirming care, and that has to do with health insurance coverage, right? So, but Medicaid, Medicare, private insurance, and particularly private insurance for federal employees who are rampant here in the Washington area. All of these plans, put forth significant challenges to folks obtaining and accessing gender affirming care. And so a big part of our practice is handling insurance appeals. And so we're out there, knocking those cases down one by one by one, but we're also advocating at higher levels and sometimes partnering with law firms who are undertaking class action or larger systemic suits to make sure that those changes are more widespread.
Excellent, thank you. There's another question from the audience, and what matrix are you all using to track outcomes? And I was wondering if Sonia can help us with that, especially what matrix we should be thinking in the areas of health equity to track those outcomes. I think you're muted, Sonia.
What we have now in place, we're looking at our UDS data tracking system as was one tool, if you will, but we also are looking at developing other tools so that we can have more concrete ways to track health equity and assess health disparities. It's a great question, so thank you very much for asking it, and more to come.
Excellent. Erin, Teresa, Andrew, or Kayla?
So we're always looking for ways to improve our data, and what are we tracking, what lines can we draw, what correlations, and so one example of what we're tracking is return on investment in terms of our landlord tenant work. So looking at how much money are we saving the community in unjust judgments or unnecessary judgments, things like that. Also looking at time extension. So in Philadelphia, from the day that the judgment is entered, you have 21 days until you can be locked out. And so how many times we're able to negotiate, or on average, the extension that we can secure for our clients. And then looking at our partnership with TPAC, we're looking at the impact on viral loads and trying to draw the correlation of providing legal services promotes healthier outcomes and ultimately slows or mitigates consequences of the virus. But that's to be determined.
Excellent, thank you. Erin?
And we too have been trying to look at both viral load suppression and the impact of legal services and insurance navigators on ultimately on the viral load suppression factor, as well as missed appointments, whether patient engagement improves when you've been touched by patient navigator and or lawyer. And we did a kind of analysis of 4 years of data related to that, and showed that people who were touched by a lawyer or our insurance navigation team in conjunction with that had better viral suppression rates and lower missed appointments. So we were seeing kind of more engagement overall from those folks. And then we do track kind of all sorts of outcomes related to the legal outcome on the case, but also around like these clinic engagements and using that outcome data on trends. So we're about to wrap up. Today is the deadline for Medicare Part D enrollment. And so we look at, all the plans we enrolled people in, how much money did we potentially save by making a shift? And then we think about how that could be lifted up in engagement or work with CMS and others around the design and issues around Part D plans overall.
Yeah, I think one other thing I'd like to mention, you know, when you talk about tracking outcomes, the question is, well, what outcome are you talking about, right? Because we can look at our patients and our clients' engagement with us from so many different angles and at so many different points in time. And one thing that I think it's important to talk about is to look at the clients and patients who drop off, right? Who are engaged with us for a week or two or even 6 months, and then they disappear. And then trying to understand, you know, what did we do wrong, or what could we do better, or what systemic challenge popped up that or other life challenge prevented this person from continuing to move forward towards the health-related legal goal that we were all focused on. And that's something that I think between the legal team and the public benefits team, you know, we're able to hone in on that in a more proactive way. Sometimes we can sort of sense, well, we know that this person is not going to have access to a telephone because for whatever reason, because the minutes will run out early in the month, or they simply don't have the ability to maintain a phone. So we get the contact information for one of their family members or one of their neighbors or friends, or, you know, some other means of reaching out to them so that we can try to maintain that connection. So that's just one example.
Excellent. Thank you so much. And I know we're short of time and we have a few slides about resources, but before we close out, just make sure that complete the evaluation link Bethany just shared with everyone else. But I do have one last question, and if you can answer it in a few minutes. You know, a lot of the folks may be thinking about starting an MLP, serving people living with HIV. So if you can share some words of thoughts and wisdoms and to-dos and not to-dos for those thinking about establishing new MLPs, that would be great. Teresa?
Sure. The first thing that comes to mind is money. So thinking about what's sustainable. You know, is it going to start with, say, a fellowship, but where's the money going to come from after the year? Because it's MLPs don't just start immediately. There's a lot that needs to go on behind the scenes before you're actually on the ground. So thinking through, how can we make sure that we're starting something that we can sustain, and really thinking about, you know, we started some MLPs and thankfully they've thrived with kind of a prayer and a 2-year fellowship. And then we've now, as we've kind of gotten more savvy with it, we've realized there are other ways to do this where there's going to be a steadier income flow. So just thinking about money.
Sonia?
I guess what I would just like to share in terms of, as I laid the framework around the landscape from circa 1987 to present, I would just like to say how you do your quote unquote marketing to make sure more people are aware that MLPs actually, you know, that you exist. It's important that folks know that you exist. So I don't know, you know, exactly how you do your marketing. Is it inside of the actual environment, if you will, but just so that people can know, because it's so important, because that would have been one of the fetches to bring it back, you know, in terms of making sure people are aware. And so from this point on, it'll be a part of the discourse in terms of what I share. Is so important.
Excellent.
Mm-hmm.
Thank you.
Thank you. And may I also say one thing that I know we should not do, that I did, and I apologize to the audience. I did use an acronym that I did not define, and I said UDS plus, just like the whole world knew UDS plus, but it's our uniform data system that the Bureau of Primary Health Care uses. So I wanted to make sure that I define that. Thank you.
Excellent. Thank you so much for those great presentations, insights, points. We're grateful. Thank you for all of those who joined and decided to stick around for 90 minutes. We have a few slides at the end with resources to share, a few publications related to medical legal partnerships on RFAs that are currently open from HRSA with deadline January the 17th. Next slide. The publications that I share, mention to you. Next slide. And Sonia also shares some resources related to wellness and World AIDS Day meditation. So Sonia, you want to add anything else on that?
I guess the important part about that World AIDS Day meditation, if you will, it is free. You know, Calm is not a free app, but this particular World AIDS Day, the fact that they even had it was important in terms of sharing with the world. And they use at the end of the meditation, they use the word, a South African Zulu word called Ubuntu, which means compassion and humanity and collective wellness, how we all need to work together. And from an important meditation guru, Sharon Salzberg, she says, when we really examine kindness, we find it is a deep and abiding understanding of how connected we all are. So thank you, and please tap onto it and you know, have the mind so that you can relax and continue the work.
Excellent. Thank you so much. And that was an excellent goal to wrap this up. Thank you.
Thank you. Thank you all.